Everybody, and thanks Dr. Anita once again for inviting me for this course. And Dr. Rath, it may be a debate, but I'm not against external DCR. I also do external DCR, so let's not put it. Let's bring out the indications for endoscopic approach. I'll put it that way. I think that's a better way of going about, because it has its own indications, which I've experienced. When I started treading on the laser DCR, everybody told me that it's a useless procedure, don't buy the machine, don't ever indulge into it. But once I started doing, I showed the results, I modified the techniques which were already reported. Now our technique is reported in OPRS, so it is like established technique. So you need to, before judging anything, you need to work on it, and you can actually modify things accordingly. So again, as I said, no debate. Gold standard, yes, it is a gold standard. I believe it's a gold standard. Avoidance of scar, Dr. Rath has said you can adopt transconjunctival techniques and all those kind of techniques. Why do you want to unnecessarily spoil your very nice conjunctiva when you can have other approaches? I wouldn't, if I have to get my external DCR done, I will never go for a transconjunctival approach. I'm very clear about it. Now, talking about the morbidity, see, when I have 7 patients of DCR lined up, I would finish. It's a daycare procedure doing an endoscopic procedure, whereas an external DCR, you may have some amount of bleeding post-op. So now as a routine, when I want to finish, we have limited beds for our patients. So what I would do is I would do a lot of endoscopic cases, only the complicated and those which would need a hospital stay for some reason I may, and whatever we say, the patients may have a post-operative, you may require to watch the patient when you're doing an external approach. So saying that all DCRs are a daycare surgery is, I think, not correct when you go for external approach. Whereas laser DCR, positively you can send home. We have done so many theses by now that I can vouch for it. The local anesthesia part, Dr. Rath, I do all my cases in local, so that's ruled out. I don't do it in GA. Okay, and yes, the morbidity is far less. There is no debate about it. We have already reported the patient can go back to work very fast. Simultaneous, if you have, most of the time now I'm able to handle the DNS and everything, only high DNS where you can't put in your endoscope. There you have issues, but if you have mid DNS and you have, mild and moderate DNS, you don't need any ENT people, you can easily see. Because the advantage of laser DCR is that you are going through the canaliculus and you can actually, you're so used to doing those things that you know where exactly to fire. Even if I don't see endoscopically, I can make a opening now. It's so simple to do it. And the learning curve is not much. All my residents, of course, you have to learn the external DCR first. You can't, jump onto, you can't start doing phaco without learning ECC. It's similar. So you have to know the basics. You should know what you're trying to do. So again, that's it. Equipment, yes. Equipment you need, and unlike the retinal lasers, the laser probe here, you're cutting it every time. So it's a recurring cost. I agree totally about it. And you have to be careful. You have to learn the endoscopy properly. And stents. Okay, we did a study and we found that you don't really need stents. Although again there are reports of endoscopic procedures where they say that you need to put in MMC and you need to put in stents to increase the the success rate. But we have already, I'll just show you the studies. We have done this study and we found that there was no additional advantage in a primary laser DCR of putting a silicone stent, and instead of, it actually incites more inflammation and those kind of things. So if you have I'll show you how large, the opening has to be large. Initial reports where they had a lot of failures were small ostium sizes. If you enlarge the ostium size, that is, you do a laser and you augment it using a Blakesley source to about 8 to 10 millimeter, your ostium size is sufficiently large, and we have followed up these patients over years now. And the failure rates are very less. They are more than 90% success rates now. In fact, this is another case where, classically it was said that you couldn't do in DNS patients the endoscopic, but again we have published this. We can easily do it, but of course high DNS where you cannot see the size, the site where you're making an osteotomy is difficult, and you should avoid those patients. So you can do it in mild to moderate cases. And then which laser to use, again a confusion. So you should use 980 nanometer laser, which is a contact laser, and it gives a very good, and you should not fire it when it is in the air or it is touching the soft tissues. That's the crux. If you do that, you get canalicular burns, you have a lot of burns. I'll show you the complications I have created over my learning. This is, I have created, this is okay. So now we, and you said laser conjunctival, this conjunctival DCR is not to be done. I have already published 2 series now, and you know, this, of course you have to be careful that your osteotomy has to be low down. If you make an osteotomy which is higher up, the sum can occur in a conjunctival DCR also. So laser is no preclude to this also. And other thing is, you have to be very careful how you fire. This was a patient where we had these burns, and be very careful about your laser probe. These are the things which initially we were maybe not, and this heart patient was diabetic and there were problems, but be very careful. You check the laser, you should not fold the laser probe and all that so that it starts firing. In conjunctival DCR, again, we have had very good results with the laser DCR. Only thing is, you have to fix the tube well. In fact, endoscopically, you can see where your tube is positioned. So again, now just 2 minutes, 1 minute more. If you have a patient like this, doing an external DCR in one sitting is going to take, you know, a little time. If you do laser DCR in the same sitting, it is much easier. So bilateral DCRs, if I have to do, I would go for an endoscopic approach. I have patients with bilateral, you know, NLDO with bilateral cataracts. So I keep waiting for each procedure. I cannot. I have no time. That's how actually I started, you know, doing these things. So I would do laser DCR in the same setting. At least within 1.5 months, the patient is going to be all right, and the cataract in next 2 weeks. Now this is one indication where currently I will soon be publishing acute dacrocystitis. Laser DCR is the procedure of choice, and we have already seen this. I don't think there's time for video left. Should I or should I not? No. Okay.
How long is it?
It's a short video. I'll just run it. It's a very short video. So इसको play करेंगे जरा? पता नहीं आपका mouse इसको correspond नहीं कर रहा. Okay. So this is the procedure. You just you know, enlarge the punctum, put the. Now here, if you try to do an external DCR in the first setting, what is going to happen? The tissue is going to get necrosed and you will have problems. So this is the transcanalicular approach. This is the probe being passed, and without, you know, causing any discomfort to the patient, you can easily make an opening. This is on the left side. You see this is the middle turbinate, and at the root of the middle turbinate you have to create an osteotomy, and you can. Besides that, you should always take the pus culture and send it for sensitivity when you're doing these cases in acute DCR, acute dacrocystitis. Why? Because if you do a surgical procedure and your organism is not responding to your antibiotics, you may end up with, you know, preseptal cellulitis and those kind of things. So always send it for culture sensitivity, and we have had very good results. I have done almost 100 acute dacrocystitis with laser DCR. So I think till I report, nobody will believe me. So that's the, okay, I think. So the crux is create a wide osteotomy, and it should be placed at the bottommost part of the lacrimal sac. Avoid damage to the nasal mucosa, because if you don't do your endoscopy properly and you cause adhesions in the nasal mucosa, that may lead to your, you know, post-operative failure. And of course, my most important indications are when you have to do a bilateral case or acute dacrocystitis. Others, of course, you can do. And thank you so much.